Welcome back guys. Now in this video let's discuss about third stage of labor. Guys, this topic was discussed under 3 parts. In the first part of this video I will be mainly discussing about third stage of labor and active management of third stage of labor. Now let's begin. Guys, what is the average time taken for the third stage of labor? It will be somewhere around 15 to 25 minutes. Actually it will be 15 minutes. The main event in the third stage of labor is, we have already seen the first stage of labor and second stage of labor. There itself we have discussed, but again in the third stage of labor the main event is the placental separation. Okay. What is the active management of third stage of labor? That we will discuss later. But if you do active management means, see, you are involving in the process of separation of placenta. Okay, see, with involvement of the obstetrician, the placenta is getting separated. So for active management it takes only 5 minutes. Why? Because the doctor is trying to remove the placenta. Now if third stage of labor, if it is more than 30 minutes, for the separation of placenta, if it takes more than 30 minutes, it should be considered as prolonged third stage. Okay, so these are some important direct single liner kind of questions which will be coming up in the exams. Now after this, let's see what are the signs of placental separations. Okay, there are certain signs with which we can know that placenta got separated from the uterine wall. Those signs include sudden gush of blood into the vagina. Okay, once the placenta separates, there will be bleeding, and that bleeding will be coming out of the vagina. That's a one sign. Okay, sudden gush of blood which will be coming through the vagina. Uterus become globular, okay, firm and palatable. These are the signs which you can see, and a palatable uterus is the earliest sign. You can also see a sign called as Schroeder's sign. What exactly is this Schroeder's sign? Fundal height raises as placenta got separated. Okay, guys, it's very logical. Please think something like this. For example, if this is the uterus, if placenta is present somewhere over here, for example, the placenta is lying in the fundal region. Now this placenta, it almost weighs 500 grams. We all know this. See, this 500 grams is pulling the uterus little bit down. Okay, this weight of the placenta will be pulling the uterus a bit down. What happens if placenta gets separated? If placenta is getting separated means, see, this is drag by the placenta. Okay, the drag by the placenta is going to be lost. So the uterus will raise a little bit higher. So this is known as Schroeder's sign. What exactly is Schroeder's sign, guys? Fundal height raises as placenta got separated and moves to lower uterine segment. Placenta is getting separated, so the drag by the placenta, okay, the gravitational drag by the placenta is going to be lost, so fundal height raises up. This is Schroeder's sign. And what exactly is Kushner's sign? Okay, absence of umbilical cord retraction on suprapubic pressure. Guys, let me show you a small diagram so that you can understand it in a better way. For example, this is the uterus, here is the placenta, and this is the umbilical cord. Guys, please concentrate. There is this woman who is lying. You have applied suprapubic pressure. Okay, delivery of the baby is happened, second stage of labor completed. Now if you apply suprapubic pressure, or if you try to push the abdomen towards the head, what happens? Actually, with the movement of the uterus, placenta will also move towards the head. The umbilical cord also retracts back into the abdomen. Okay, this is what happens normally. But when placenta got separated from the uterus, when you try to apply the suprapubic pressure and try to move the uterus a little bit towards the head, yeah, uterus going to move towards the head, or uterus going to move upward. But As the placenta is already separated, the retraction of umbilical cord doesn't happen. So this is known as Kushner's sign. Okay. So Kushner's sign and Schroeder signs are the signs which are seen with the placental separation. What exactly is Schroeder sign? Schroeder sign is increase in the fundal height. What is Kushner's sign? Absence of umbilical cord retraction upon applying the suprapubic pressure. Both are signs of placental separation. Okay, what is the earliest sign? Uterus becomes ballotable. Now after this, let's talk about the methods of placental separation. There are two main important methods which are known as Schell's method and Duncan's method. In Schell's method, please concentrate here in these images. This is Schell's method of placental separation, and this image is about the Duncan's method of placental separation. Please concentrate in Schell's method. Separation begins from the center, but in Duncan's method, separations begin from the periphery. See in the image here, the separation of placenta is happening from center. For example, if this is the fundus of the uterus, if this is the placenta, placenta is going to separate from the center, but the periphery of the placenta, they are still intact. Okay, so this is a very important point you have to keep in mind. Schell's method starts from center, separation starts from center. In Duncan's method, separations begin from the periphery. As the separation is happening from the center, do you expect that there will be pervaginal bleeding? No, definitely not. See, there won't be any pervaginal bleeding in Schell's method. Why? Because all the blood, okay, all the blood is going to accumulate back to the placenta. So bleeding is only seen after entire separation of placenta because blood got accumulated back to the placenta. But in Duncan's method, as the placenta is getting separated from one end, you can see active bleeding through the vagina. Okay, that's a very important point. So take the point, bleeding seen when separation starts. As the blood is getting accumulated back to the placenta, all this blood will clot and forms a retroplacental clot. Okay, this is a very important MCQ. Retroplacental clot is seen with which type of placental separation? It is Schell's method. With Duncan's method, there is no such retroplacental clot. Now, please concentrate. We all know that the placenta have two sides, fetal side, maternal side. In Schell's method, the fetal side, okay, this is the fetal side. Why? Because umbilical cord is getting attached towards this side. Okay, so this is the fetal side of the placenta, and we all know that fetal side of the placenta is going to be shiny. So shiny fetal side is going to be seen first. But with Duncan's method, the reddish maternal side is going to be seen. So shiny fetal side presents first. Here reddish maternal side presents first. Out of these two, which is most common? Most common type of placental separation is Schell's method, and this is also something good. Why? Because there is no too much amount of bleeding. All that blood, for example, if this is the placenta, if it's separate from the center, all the blood will accumulate in that area, so that there won't be too much amount of blood loss. Okay, all that blood is going to come there and it's going to accumulate over there and it's going to form a clot, and that clot will create some mechanical pressure so that there won't be extra bleeding. Okay, so Schell's method is considered to be a very good method of placental separation, and least common type is the Duncan's method, which will be accounting for somewhere 20%. Now after this, line of separation of placenta. Okay, for example, same fundus, this is the placenta. See the line of separation, that line is zona spongiosa. So line of separation of placenta occurs in zona spongiosa. That line is known as zona spongiosa. Now see, what is the blood loss? Normal blood loss happens during vaginal delivery. Why this is important? See, why we are discussing the amount of blood loss in third stage of labor? Because there is some importance. What is that? There is this condition known as postpartum hemorrhage. to define postpartum hemorrhage, you need to know what is the normal amount of blood loss happens in normal vaginal delivery, C-section and hysterectomy. See, please concentrate. In a normal vaginal delivery, almost 500 ml of blood will be lost. Okay, up to 500 ml, which is normal. Normal vaginal delivery, 500 ml blood loss is something normal. But above 500 ml should be considered as postpartum hemorrhage. With C-section, 1000 ml blood loss is okay. But there is this female who have undergone C-section, but the amount of blood loss is more than 1000 ml. Now we have to consider this as postpartum hemorrhage. In hysterectomy, almost 1500 ml of blood loss will be seen, and that is something normal. Now after this, let's talk about active management of third stage of labor. What exactly is active management, guys? See, we are assisting in the separation of placenta. Okay, placenta is not separating on its own. We are assisting in the separation of placenta. First of all, why we have to do active management of third stage of labor? Why? Because there is a risk of postpartum hemorrhage. If you do active management of third stage of labor, the risk of postpartum hemorrhage will decrease. The risk of maternal mortality will decrease. So that's the reason why we have to do active management of third stage of labor, and then this is something very good. So what are the components of active management of third stage of labor? We are going to give a drug which is a uterotonic drug. See, if you give this uterotonic drug, it contracts the uterus, causes separation of placenta, and such uterine contractions will also clamp down the bleeding blood vessels. Okay, after separation of placenta, there will be bleeding. So those bleeding blood vessels should be ligated. For ligating those blood vessels, uterine contractions are needed. So I am going to give a uterotonic drug. After this, I am going to do delayed cord clamping. What exactly is delayed cord clamping? Why this is important? Discuss later. But first I will be giving a uterotonic drug. I will be doing delayed cord clamping, not early cord clamping. Delivery of the placenta by controlled contraction. Okay, see, once I confirm myself that placenta is separated, I am going to take out the placenta by controlled contraction. Okay, so these are the components of active management of third stage of labor. Again, let me repeat. What are the components? Uterotonic drug, second one is delayed cord clamping, and third component is delivery of placenta by controlled cord traction. These are the three components. Guys, please concentrate. Uterine massage. Okay, uterine massage is not a component of active management of third stage of labor. Why this is important? Because usually in exams, here and then, this will be coming. All of the following are components of active management of third stage of labor, except. So please remember, uterine massage is not a component of active management. See, this uterine massage, we will do it for treatment of postpartum hemorrhage. Okay, we will be doing this uterine massage as a treatment option for postpartum hemorrhage. But there is no postpartum hemorrhage now. We are in a normal third stage of labor and we are assisting it. How we are assisting it? By three ways: uterotonic drug, controlled contraction, and by delayed cord clamping. But there is no uterine massage. Very, very important. Also here I am quoting the statement from the book. Neither massage nor downward fundal pressure is employed, which means we are not going to do uterine massage in active management. Okay, very important point. Now after this, let's talk about the very important component. Out of those three components, the most important component of the active management is giving uterotonic drugs or giving oxytocin, okay, which means uterine contractants. So what and all the drugs I can use? The most important drug and most preferred drug by the WHO, that is oxytocin. Okay, so oxytocin is the preferred drug and the drug recommended by the WHO. How much I am going to give? I will be giving 5 to 10 units IM. So 5 to 10 units IM oxytocin will be giving, okay, will be given. So it causes the uterine contractions. See, other than oxytocin, some other drugs can be used, which include ergometrin or methyl ergometrin. The dose is very important. If it is ergometrin, 0.25 milligram, methyl ergometrin, it is 0.2 milligram IM, okay, which route? Via IM. See, the most important side effect of this ergometrin is sudden hypertension. Okay, so if you give rapidly, it causes sudden hypertension, very important MCQ. And there are also certain contraindications that in certain females, this methyl ergometrin should not be given, or this methergin, okay, other name, should not be given. So what are those contraindications, guys? Very important MCQ. Contraindications for ergometrin or methyl ergometrin, like the mnemonic is POTER, P-O-T-E-R. See, P for those females who are having preeclampsia and eclampsia, okay. P for preeclampsia and E for eclampsia, that is pregnancy induced hypertension. Also female with the heart disease, okay, heart disease or organic heart disease. If a female is having twin pregnancy, don't give methyl ergometrin, and this methyl ergometrin should not be given in a Rh negative female, okay. These are very important contraindications, okay. So POTER, P for preeclampsia, eclampsia, a female with organic heart diseases, in twin pregnancies, and in a female who is Rh negative, okay. So these are the places where ergometrin should not be given. Also you can give injection of prostaglandin F2 alpha, okay. See, this is a very important drug, and this is a better than oxytocin. We used to say, okay, this is the best drug. Like this will be used especially in the treatment of postpartum hemorrhage. Now we are discussing normal third stage of labor and its active management, okay. But as of now, please remember this point: prostaglandin F2 alpha, which is also known as carbiprost. This is given intramuscularly and it also causes sudden hypertension. How much we have to give? 200 micrograms. This is a very important, okay. So 200 micrograms IM, it also causes sudden hypertension. Ergometrin or methyl ergometrin will also cause sudden hypertension. You can also give tablet misoprost, okay. Misoprost means prostaglandin E1, okay. It's not mifepristone. No, mifepristone will be used in the termination of pregnancy. I am talking about misoprost, okay, not mifepristone. Very, very important. Misoprost, how much we have to give? 600 micrograms, okay. See, for active management of third stage of labor, we can give 600 micrograms. But the same drug can also be used in treatment of postpartum hemorrhage. There we can increase the dose up to 800 to 1000 micrograms. But in active management of third stage of labor, usually 600 micrograms orally or even rectally we can use this misoprost, which is PGE1, okay. Now after oxytocin, that is the first component is completed. The second component of active management is delayed cord clamping. What exactly is delayed cord clamping and why it is important? For example, if this is the umbilical cord, you have to clamp the umbilical cord, right? You have to separate the mother and the baby. So you have to clamp the umbilical cord. See, it is better to clamp after 1 minute after delivery. Please concentrate. Clamp the cord after 1 to 3 minutes, at least one minute, okay. This is known as the delayed cord clamping. Why this is important? Because if you give that much amount of time, all the blood which is present in the umbilical cord, okay, this is the fetal blood, all this blood will be taken back by the fetus. So if all this blood is going back to fetus, the iron component which is present in this blood, almost 80 to 100 ml of blood is present in the umbilical cord. So all this 80 to 100 ml of blood is going to be taken back by the fetus. So almost 50 milligram of elemental iron will be taken back by the fetus, which will prevent anemia in the fetus. Okay, so that's the reason why we will be doing delayed cord clamping. So what is the advantage, guys? The advantage is, please concentrate. The advantage is 50 milligram of elemental iron present in the cord goes to the newborn, which prevents the anemia in the baby. But when we have to do early cord clamping, if there is any maternal or fetal distress, or if the mother is having, baby is having any heart disease, we will be doing the early cord clamping. Maternal distress or fetal distress or baby with some heart problem, in these conditions we will be doing the early cord clamping. So first component of active management is completed, that is the oxytocin. We have discussed oxytocin, ergometrin, methyl ergometrin, prostaglandin F2 alpha, misoprost, all these drugs we have seen. We have also discussed about the delayed cord clamping, that is the second stage or second component. Now after this, let's talk about the delivery of the placenta. See, once you confirm that the placenta is separated, you have to take this placenta out by controlled traction on the cord. Okay, you have to pull the cord in a controlled fashion so that placenta will be coming out. Now, how to do that? Please concentrate. With one hand, even in this image it is very clear, with one hand the fundus is pushed towards the head, and with other hand there is this gentle traction applied on the cord. See, with one hand there is this gentle traction is getting applied on the cord, and with one hand the uterus is pushed, or the fundus is pushed towards the head. Why? Because see, if you don't follow such maneuvers, there is a risk of uterine inversion. Inappropriate contraction causes uterine inversion. For example, concentrate here. If this is the uterus, here is the placenta, this is the umbilical cord. Now you try to apply inappropriate pressure, okay, inappropriate traction. What happens? So that, see, please concentrate, uterus will become something like this. Okay, the fundus of the uterus is going to invert, that is the inversion of uterus. So here is your placenta. So inversion of uterus will be the result of inappropriate management of third stage of labor. So what to do? With one hand uterus is pushed upwards or towards the head and backwards, upwards and backwards, and with other hand traction is given on the cord downwards and forwards. So this is controlled cord traction. Now please concentrate. If placenta is undelivered after 30 minutes, okay, see, you are trying to do the active management of third stage of labor. Actually third stage of labor should last for 15 minutes. You are trying active management. Active management will be somewhere from 5 to 10 minutes maximum. But even after 30 minutes, if placenta is not delivered, this is prolonged third stage of labor, and this is called as a retained placenta. Placenta got retained in the uterine cavity. Now mismanagement leads to, mismanagement means inappropriate traction on the umbilical cord, will lead to uterine inversion inside out of the uterus. Okay, so uterus is going to, for example, if this is the uterine fundus of the uterus, it will be coming something like this. Okay, it will be coming something like this. Okay, there is inversion of the uterus. Okay, now let's talk about some important points. Guys, out of all the three components of active management of the labor, third stage of labor, the most important component is giving oxytocin or giving a uterotonic drug. What is the most preferred uterotonic drug? The most preferred is being oxytocin. 5 to 10 units should be given intramuscularly. Okay, never give oxytocin as IV bolus. You can use it as IV infusion, that's a total different thing, but preferred is 5 to 10 units intramuscularly. Oxytocin is the preferred drug by the WHO. Now see, what is the drug of choice to prevent the postpartum hemorrhage? It is oxytocin. Later in the second part of the video, I will be discussing about the treatment of postpartum hemorrhage. Even for the treatment also I will be using oxytocin. Even for prevention of postpartum hemorrhage also I will be using oxytocin. So the most preferred drug for prevention as well as treatment, it is oxytocin, oxytocin, oxytocin. Okay. Now how much oxytocin should be given? 5 to 10 units intramuscularly after delivery. Okay, so we have completed the active management of third stage of labor. All important points are covered. In the second part of the video, I will be discussing about the postpartum hemorrhage. Hope the video is helpful. Thank you.